age population, let's say 20 to 50, 20 to 60, I don't know, depending on your retirement age. Now I think Sri Lanka is considering increasing the retirement age. So the productive population will be getting less and less. And you are not producing more children because your fertility rates have gone down, which is a good thing. That's why the good news, bad news business. The good news is that you have done something positive. All this is a result of all your fantastic achievements in health. You reduce death rate and reduce birth rate. That means people are living longer. You are not producing more kids. So there are fewer children. That means there are fewer people in the productive workforce eventually. So in this thing, you will see, what does that do? It increases your dependency ratio. Dependency ratio is the ratio of people who are not working divided by people who are constructively working and productively engaging in economic activity and therefore producing wealth. And if that proportion goes beyond a manageable limit, that's what actually is happening already in Japan. So Japan is facing this huge problem that they don't have enough people, and how are they dealing with it? Mechanization. So they are making machines do things which human beings were doing before, right? So Sri Lanka needs to think about that. You think about that now, that means by the time the transition reaches that stage, you will be prepared for it, best prepared for it. If you don't think about it now, it will be too late. And that is one message about demographic transition. The other message is, again, there is a good news, bad news story here. There is something called demographic dividend. You might have read about this, demographic bonus, demographic dividend, they use this term. There is a small window where that population which was in 0 to 4 has come to the middle of the pyramid, where they are all in productive age group. So you have a bulge of the labor market. So you can actually produce more and more and more at that time and increase your national wealth. Therefore, you have a buffer by the time that group is very old, right? So that requires very good policies. It won't happen by itself. If you have a lot of people who are in the working age but you don't have jobs for them, they will all be unemployed. Or you don't have good jobs for them. You may have unskilled labor that is not going to contribute to the economic development, as well as if you had trained them well, if you had tooled these people to be savvy in computers, savvy in English skills, savvy in math skills, which are all skills which apparently in Sri Lanka still need a long way to go. So these are education sector issues. But related to that is the demographic transition, which of course falls within the health sector issue. Okay, what then does it do for health? You project the increase in the proportion of elderly age groups. You see this thing, 60 to 69 is the black portion of the bar, 70 to 79 is the gray portion, and the white is the plus 80 plus. After about 2090 or 2100, then slightly it starts to come down. Sorry, I am taking this time. But basically what you will see is that not only are the aged proportion increasing, the very aged proportion is increasing, that white bar. It's very difficult to make them work. You can increase the retirement age to 65 or 70 even, but you can't increase it to 90. So even if you do, their productivity is not going to be as good. So that is an important thing to take care of. Now this graph basically shows Sri Lanka is moving even faster than any other part of the world in terms of aging. And the female predominance, I already talked about, the females will be higher in the older population. So, and then therefore, what on earth is epidemiological transition? Epidemiology is the study of distribution and determinants of disease. That's the definition of epidemiology. So if the transition in epidemiology actually shows that the kind of diseases that you are going to have is changing. And that's what these graphs will show. You have infectious diseases in that orange line, which has come down drastically, but you have diseases of the cancer, circulatory system, diabetes mellitus, etc. going up, okay? And the proportionate mortality ratios, if you look at the WHO CRO region, which is Southeast Asia region, compare that with Sri Lanka and compare that to the European region. Sri Lanka is more akin to the European region. That means the black bar is the non-communicable diseases. That's much more in Sri Lanka. And the hashed bar is injuries, which is also non-communicable, but the WHO presents it separately. You add the two, then you see that actually Sri Lanka is almost like a European country. Okay, so these are important things. This is basically showing the same thing through life years lost. and injuries. Injuries pose a particularly high burden in Sri Lanka. This is very outstanding graph, which somehow we have to explain why that is the case, whether it is because of urbanization and the road traffic accidents are more, whether you're not yet there, you're building infrastructure, but the behaviors in driving are not yet keeping pace. We all see that on the road. So those are things. So now I just want to go through this list very quickly. These are the issues that we have identified together with the Ministry of Health through several workshops on what are the systemic issues that need to be addressed. Number one, we are very clear that health infrastructure needs to be developed. It's not yet there. And there's a lot of hospitals you go around and you find that they are functioning okay, but there's a lot of things that need to be improved. Equipment need to be built up, but also the buildings. There is health management information system. Still, Sri Lanka, which has a reasonably good database, all the databases are paper-based. And so there is no coordinated, integrated information systems, and these are important for you to do planning management and quality decision making, and also for patient management. Healthcare quality assurance, non-existent at the moment really. There is no quality secretariat. We helped the Ministry of Health to develop one, and it's not yet fully functional. And there are no standards, there are no accreditation. There are some guidelines and so on and so forth, but basically quality assurance mechanisms need to be developed into a systematic manner. Hospital and pre-hospital emergency care. In Sri Lanka, actually, there is no ambulance service. There are ambulances, but the ambulances are used to transfer patients from one hospital to another, not from the point of emergency to the hospital. So if you have a heart attack or if you have a road accident, you are basically having to take a trisha or the modified ambulance that Dr. Mahipala was talking about. But that's really a special case that they developed for the IDPs. Across the country, there is no ambulance system. In Colombo, there are some private ambulance companies which richer people can access. But essentially, there is no ambulance. It's a very, very urgent thing. Otherwise, you can't call yourself a middle-income country health system. Development of human resources for health and health financing issues and private sector engagement. I don't want to elaborate, but those are, I think, self-explanatory statements. Where is the money going? Show me the money. Government budget for health is almost $1 billion per year. That's quite a lot by comparison to the overall government budget. The problem is that's not enough. It's still only 3.4% of GDP, and out of that, 1.8% is coming from private sources, from out of pocket. That has been declining over decades in terms of percentage. In terms of rupees, it is not declining. But in terms of percentage of GDP, it is declining. Thus, the public spending is 47% of total health expenditure. It accounts for 90 to 95% of inpatient care and roughly about 50% of outpatient care. Private and mostly out-of-pocket spending, it is what really is now a predominant portion of your spending. Is that a good thing or a bad thing? It may be a good thing for rich people. They have money to spend, they spend from out of pocket. But if the poor who go to a public facility and they don't get a particular test or a medicine and therefore they are going to have to buy it from the private market, that's not a good thing, especially for a Sri Lankan vision of a social welfare state concept. It is not a good thing. And here you see the health expenditure as a share of GDP, and you see Sri Lanka is much below the trend line. China is much more, and Maldives is higher, and Bhutan and Malaysia, Thailand, we have seen, they are all higher. Sri Lanka is below the trend line here. On a per capita basis, also Sri Lanka is below the trend line. And these are different ways. I don't want to go into the details, but different aspects of healthcare where public health spending is going. But essentially what you find is Sri Lanka's spending on ambulatory care is very low. There's a big spending on inpatient care, hospital, residential facilities, but the spending on ambulatory care or outpatient care is low. There's a high spending on retail of medical goods, which is all coming from private actually. There's a heavy reliance on hospital inpatient care. The hospital discharges per 1,000 population for Sri Lanka is higher than Hong Kong, Australia, Korea, OECD. It's an incredible bar graph. I could not believe this data. The public and private expenditure on selected medicines, you will see some medicines are more heavily subsidized by public sector, some medicines are more spent from the private out of pocket, and especially statins and things like that, non-communicable disease medicines are being spent from out of pocket, which is going to be a huge burden on the poor people because, as was pointed out, NCDs are no longer just a rich man's disease. So the future is challenging. The business as usual will not do. Past successes were low-hanging fruits, whereas now NCD prevention and treatment will be more expensive than communicable diseases and maternal and child health. Middle income status raises expectations of a more modern system. Your population is more educated. They are not going to take poor quality care anymore. There's going to be a rebellion if we continue that. So a great focus on quality, efficiency and equity will be needed. Equity was talked about already. Fiscal space constraints. because your budget, your revenue generation in Sri Lanka is very low. Sri Lanka only generates 16% of the GDP, or gross domestic product, as tax revenue. I have only one more slide, madam. So that being the case, how are you going to meet the future for health financing needs? It requires innovative thinking, especially if your goal is all healthcare is free for everyone. There is no rationing. Even the rich man is supposed to get the care for free if they go to the hospital, which some of them do. Many of them may go to the private, but some of them do. Maybe not the richest, but the upper middle class, they go. Because some of it is because private care is not considered to be as high quality as public care in this country. Some of the most of the specialists are actually public doctors, right? So there is a lot of issues there which need to be addressed innovatively. This is the last slide I want to show, which is health sector cannot do it alone. I think there's a little bit of that which already Dr. Abhay talked about, the international agencies. But I want to talk about partnerships within the country. We are here at the Defense University. Defense sector has a contribution to make to health. But of course, we all know education has a contribution to make, social protection, roads, water supply, agriculture. But here I put defense in block because you have a big contribution to make. With the way this conference is organized, so well organized. And you're impressed. By the time you come here, you can give some of those organizational skills to Ministry of Health, I think, which can benefit from it. Now, Dr. Ruberu may not admit it when he was Health Secretary, but now I think you will admit that Health Ministry can do with a better organization skills. With the private sector, civil society, academia, media, you need to involve all those sectors as well. And of course, international partners. I won't repeat what Dr. Abhay has said. I will finish with a little story again on partnerships. There was a town man who was driving his car, and he was driving along the rural road. His car got stuck in the mud. He drove off the road a little bit and got stuck in the mud. He couldn't move the car again. So he was waiting on the road looking for some help, and there was a guy, village guy, who came with his horse carriage. And, you know, he stopped him and he said, "Can you please help me somehow?" He said, "Okay, I can tie my horse to your car and he will pull it out from the mud." So he tied the horse and he says, "Pull, Buster, pull." The horse did not pull. Then he says, "Pull, Johnny, pull," and the horse did not pull. Third, he says, "Pull, Coco, pull," and the horse then pulled the car and took it out of the mud. So the town guy was talking about it. He says, "Okay, thank you so much, really kind of you. If his name is Coco, then why do you call him Buster and Johnny in the first instance? Why do you call him by the wrong name?" The village guy said, "The horse is blind, and he won't even try pulling if he thinks he's pulling alone." So he called the wrong names, make the horse think that there are three horses pulling. And then he did pull. The reason why I say that is because we all need to pull together. We all need to do this in a partnership. Hopefully, our partners are not imaginary horses. Okay? Thank you very much. With that, I would really like to thank you once again for the opportunity given to me.